signed up to speak.
Okay.
Public comment.
Okay. Got it.
So,
¿Cómo estás?
Bien.
and that's yours.
Okay, first thing I have to announce.
Good afternoon. Today is June 24th, 2026, and it is 4:07 p.m. As a quorum of the committee is in attendance, I'd like to call to order the meeting of the Central Health Budget and Finance Committee. As a reminder, some of our committee members may be also participating by video conference, so the staff will be managing video and audio feeds of all participants closely to make sure we have a legally compliant meeting at all times. I'd like to announce that in order to make it more accessible to community members, we will hold public communication for the Budget and Finance Committee and the Board of Managers meetings at approximately 5:30 p.m. today, unless a member of the public wishes to comment on specific items on this agenda now. And I know we have 4 individuals scheduled to speak at 5:30. At 4? Like right now? Oh, we have 4 people that would like to speak right now, so. Right now, so. Okay, yeah, we can do it now. Y'all want to make the announcement?
Good afternoon, Board of Managers. We do have 4 individuals signed up to speak. I will read out the public communication guidelines. Please introduce yourselves by name before beginning your comments. If your comments will
But I
focus
don't know
on
who's
a
speaking first. Or Brianna.
Good afternoon, Board of Managers. We do have 4 individuals signed up to speak. I will read out the public communication guidelines. Good afternoon, Board of Managers. We do have 4 individuals signed up to speak. I will read out the public communication guidelines. Please introduce yourselves by name before beginning your comments. If your comments will focus on a specific item or issue in the agenda.
We're waiting for some instructions, but I do know that, first of all, we have public comment period, and we welcome your comments. We limit it to 3 minutes per person. And so when we get the list, we'll start calling folks by the order that they have them. Hi.
Public communication guidelines as follows. Please introduce yourselves by name before beginning your comment. If your comments will focus on a specific item or issue on the agenda, please indicate the full item number after your introduction. Each speaker will be limited to 3 minutes. Staff will be timing each speaker and will announce when a speaker has reached their time limit. Once we have let the speaker know they've reached their limit, we will allow 30 more seconds to wrap up your comment. Due to the restrictions of the Open Meetings Act, the board may be restricted in discussing any items that are not listed on the agenda for this meeting. The board may choose to set aside any new issues for discussion at a future meeting. So first, I'll call up Suzanne Daniels from Brentwood Social House.
Thank you, Suzanne.
Oh, I'm sorry. Okay, after Suzanne, we have Adam Orman from Good Works Austin, Ronnie Smoot, and T. Nguyen.
Great, thank you. Welcome, Suzanne.
Good afternoon. My name is Suzanne Daniels, and I'm the founder and owner of Brentwood Social House. I've operated my business in Austin for nearly 10 years, and I'm also a member and on the leadership committee of Good Work Austin. First, thank you for your service to our community and for considering the future of the pilot Central Health Premium Assistance Program. As a small business owner, I care deeply about the people who work alongside me. They are not just employees, they are the people who take care of our guests, support my business, create community, and help make Austin the city we all love. Like many independent hospitality businesses, I would love to offer comprehensive employer-sponsored health insurance. The reality, however, is that most small restaurants and coffee shops, like myself, operate on very thin margins. Rising costs, increasing rents, and the day-to-day challenges of running small business often make traditional healthcare benefits financially out of reach. That is why this pilot program matters. One of my employees, T. Nguyen, who's also here, was able to receive health insurance through this program after I encouraged her to apply. Before being accepted, she delayed preventative care because she simply couldn't afford coverage. Through this pilot, she was able to access regular checkups and recommended screenings that she had previously put off. More importantly, she gained peace of mind. Instead of worrying that one illness or unexpected medical issue could become a financial crisis, she was able to focus on her health and her future. T's story is not unique. It reflects a much larger need in our industry. The pilot received 77 applications for only 25 available spots. That tells us there's significant unmet demand among hospitality workers who are working hard, contributing to our local economy, but still struggling to access affordable health care. What I appreciate most about this program is that it does more than simply help pay premiums. It provides navigation, support, and education that help people successfully access and use health care coverage. It is a thoughtful investment that helps workers build stability and stay healthy. Austin's food and beverage industry is part of what makes this city vibrant. Investing in the health of hospitality workers is an investment in Austin's economy, our small businesses, and our community as a whole. I respectfully ask the board to continue to expand the Good Work Austin and Central Health Premium Assistance Pilot so that more workers like T can access the health care they need and deserve. Thank you for your time and consideration.
Thank you. Adam?
Hi, Adam Orman. I'm the owner of Locadoro and Bambino restaurants, and one of the co-founders of Good Work Austin, which has now been in existence for almost 8 years and advocates for more benefits, better wages, and supports for the small businesses that provide those for our employees. And I wanted to thank you for helping to put together the healthcare assistance program. One of our employees has benefited from it, and you'll hear a little bit of his story. But I know that this is the sort of thing that keeps people at work, that gets people back to work sooner, and that, like Suzanne said, gives people the peace of mind to go about their days and not worry that the next accident is going to sink them financially because of the medical bills, and also because they're going to end up missing work as well. So the kind of double whammy. It is really important that we continue this and grow this program and find creative ways to do so. The hospitality industry has been left behind in so many ways, and it is the largest private employer in Central Texas, in America, in fact. And we're still dealing with a place where $2.13 an hour is the legal wage for service workers who are majority female and majority people of color. Even the richest of us, chains and national, global companies, typically don't provide health care or child care or paid time off, which is where Good Work came from, was the paid time off, paid sick leave conversation in Austin. So the more that we can focus on this part of our, these neighbors, this part of our community, and the more creative ways we can come up with to get more health care to more people, the better Austin will be. So I appreciate that we've started on this road with you and look forward to figuring out how we can cover even more of our industry and help more owners who want to do right by them. Thank you.
Thank you. Ronnie?
Hello. My name is Ronnie Smoot. I am an employee for Bambino. I work in the kitchen as a line cook, do a lot of various things there. I've been in the industry since I was roughly 16, 17 years old. I got my first job in a country club waiting tables, and never in my years of being in the restaurant business have I ever been able to have health insurance at all. No place has ever provided it. Like Adam was saying, everything's been a $2.13 an hour job, or a $7 an hour job, you know, working in the kitchen. I was injured. I was just walking my dog, was bit by something, a spider or something, I don't know what, but it put a huge hole in my leg. And if I wouldn't have had insurance, or I would have missed probably over a month of work. Just with the insurance and going to the doctor, I was out, you know, 2 weeks straight. I still have a hole in my leg from it. But because I had that insurance, I was able to continue working a lot faster and continue to have a job, which was amazing. So I would hope that that this program can be continued and that it can be expanded for other people, because there are other people there that deserve it. I'm blessed to be one of the 25 people that got accepted for it, so I'm very thankful for that. And I just wanted to come here and say that thank you for helping provide that for me and the other people. Anyway, that's really just all I have to say about it. Thank you so much, and I hope that you guys continue the program and expand it. Thank you.
Tia? Did I say that right?
Hello, my name is T, and I currently work as a kitchen lead at Brentwood Social House. I've been working in food service for 9 years. The last 5 of those years have been here in Austin. I'm very grateful to be one of the 25 recipients of the healthcare program. None of my family at home in California can believe that I found free healthcare in Texas working as a baker. But I'm speaking here today as an advocate for all my peers who did not qualify for the pilot program. I think everyone deserves the peace of mind I was able to get through the program. Because when you get hired onto any food service role, including management, you do agree that you can lift 50 pounds and stand for 8+ hours. As you can imagine, it's one of the most physically demanding careers you can work. You gotta be clocked in and on the floor to be able to pay any of your bills. Especially because most of these jobs also do not offer PTO. The gambles I made when I was uninsured and unable to access healthcare are not hypotheticals. When all of my wisdom teeth breached, I risked sepsis by stretching a 7-day antibiotic course for over a month to stack my checks and then pay for surgery later. When I stepped in an anthill gardening, I kept going to work until I realized the swelling was also an allergic reaction and it spread to the lymph nodes in my armpits. I've self-diagnosed with online services for prescriptions, just hoping that what I've treated didn't have underlying conditions, or that I haven't wasted my money by buying something that wasn't gonna work. Luckily, I was right that time. Unluckily, BV is one of those things that can come back. Life happens, these things are normal. but they can be horrifying when you do not have a safety net. I'm fortunate to have my youth to gamble with, but increasingly those in food service are much older, and many of those have their own children as well. I hope that my peers can access healthcare not only for safety, but to handle themselves with dignity. Thank you for your consideration.
Thank you. Members, is there any other member of the public that wishes to speak on a specific item on this agenda today? If not, I want to thank you all for your comments. We're going to now proceed to the committee agenda. And members, we're going to move to item number 1, which is approval of the minutes of the May 27, 2026 Budget and Finance Committee meeting.
I make a motion that we approve first. I move that we approve the minutes of the May 27th, 2026 Budget and Finance Committee meeting.
Second.
Having a motion and a second, all those in favor of approving the minutes, please raise your hands. The motion passes by unanimously. By all those in attendance. Oh, sorry, the motion passes, but having a motion and a second, the motion passes unanimously with all members voting. I think that, yeah, that was a meet, yeah. 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 The second item is to receive the May 2026 financial statements for Central Health, and Nikki Riley will be presenting.
Good afternoon, Nikki Riley, Deputy CFO. The May financial statements for Central Health, all of the financials are in there. I'll just go over the highlight page, and then if you have any questions about anything else in the packet, I would be happy to answer any questions.
Thank you.
We did receive our tobacco settlement in May. It was 2.2 more than we had budgeted. So it was $7.7 million. Our property taxes are coming in on time. Direct services is $36.1 million to date, which is 44% of our budget. There's some things in there that we've noted on podiatry and rheumatology. On all of these, we have oncoming providers in Q3 and Q4, which should be a few more dollars spent in those areas to increase the percentage spent of the budget. Opioid abatement expenses were about $200,000 this month. We still have $916,000 left in the budget. $2.2 million, though, overall to spend. And grant expenses, we only really have one grant expense, which is the ECHO donation that we received. And that was $41,000 this month, $458,000 year to date. And we have $1.2 million remaining after that. That was the main things happening in May. Do you have any questions about any of the other financial statements?
Members, any questions? Are there any unanticipated expenses that you got this month that you weren't expecting?
No, it was all pretty usual.
Yeah. Great. Manager Valdes.
So for the unexpected overage that was put into our account now, do we have a designated place to spend that money? Or will that be just added to a contingency reserve or the general fund?
We budgeted $5 million this year, and so those are the resources that we budgeted to spend. And so the extra dollar amounts will roll into next year as a beginning balance of resources that you will be able to spend next year.
Okay, thank you. So we would not be able to spend that money on this coming, well, it would be this coming budget, correct?
Correct.
Thank you.
Thank you. Members, any other questions? If not, thank you very much. The third item on our agenda tonight is receive the May 2026 financial statements for community care health centers, and Joy Sloan is presenting.
Good afternoon, everyone. So for community care, we have the slides that we presented. For May, we did, so far, we're about still a $6.8 million surplus for the fiscal year to date. We've not seen any real changes in our revenue sources or our expenses in the last couple of months. We are still seeing a pharmacy margin run at about 73, or expenses run at about 73% of revenues, so about a 27% margin. And we are still continuing to see Medicaid run about 27% of encounters, so we're holding steady even though we are feeling some of the additional restrictions from the OBBA bill that was passed, or whatever that was. So we're holding steady there as well, which is good. Wages continue to run under budget. We do expect those to continue to run under budget through the rest of the fiscal year. And when we look at the balance sheet, we are seeing cash climb over the last couple months. However, we're expecting a third payroll to hit in either June or July, which will drop that cash back down to around probably 35 to 37 days cash on hand. So overall, we remain the same that we have been doing all along with no real changes operationally. Are there questions on the financials?
Members, any questions? Thank you all very much. So members, will go to item number 4, receive and discuss a presentation on the financial forecast for fiscal year FY 2027 and subsequent fiscal years, with Jeff Knodel and Nikki Riley presenting.
Okay. Thank you. Jeff Knodel, Chief Financial Officer, and Nikki Riley, Deputy Chief Financial Officer, will be doing a joint presentation. So this begins our fiscal year 2027 budget to try to have time to react to certain events that would have a either financial or service impact. The financial forecast is a very high-level financial statement. It really, financial instrument. It just really is looking at a lot of trends and known events. And so this slide shows the architecture of our long-term financial forecast, starting with fiscal year 26 as a base, and then moving into the additional 5-year, which help drive the expenditure side related around how we prioritize services. Workforce and inflation, these are expenditure variables that are necessary to account for our most valuable asset, which is our employees that deliver the services to our patients. State and local funding that can be volatile and needs to be monitored almost on a weekly basis, but there are some legislative issues that could impact that. And then areas that help inform our outlook include population growth, gaps in our healthcare system, and legislative mandates. Next slide, please. So typically, in our financial forecast, we walk through some known risk. I will assure you there are some risk out there that we probably don't know. But healthcare financing has been at times can be volatile. But here you see, related to our risk slide, a triangle of Central Health, Community Care, and Sendero that really illustrates why these risks matter, as financial or operational stress could flow directly or indirectly to any one entity. Some of those risks that could have an impact include economic downturn and inflation. And as it relates to that, typically a downturn compresses tax property value while also at the same time increasing demands for services that we provide to our patients. Regulatory and legislative changes, shift in funding levels, or as Community Care just mentioned, the OB3 non-citizen eligibility processes is certainly a risk as we move forward. ACA, Affordable Care Act, funding framework, including future tax credit policies, risk adjustment transfers, and shortened enrollment periods are just a few of the risk related to that. Physician and workforce recruitment. Again, people are our largest asset and most valuable asset. And then infectious outbreaks or cybersecurity events. These are examples of risks that can occur that require quick and substantial changes in how we deliver care. Next slide, please. So now we're getting a little bit further into our forecast process. So before we look at the actual forecast numbers, it's important to understand how we built them. So this is a process slide that walks through a three-step process that we use to estimate and project our contingency reserve balance, our overall financial resources, starting with, and I'm kind of moving left to right, starting with fiscal year 2025, which we've, it's been a number of months since we've completed the audited financial statements for FY25, but starting with truing up to actual audited numbers as a starting point related to our reserve numbers. And then beginning this year, we're always trying to improve the process. So this year we are moving through fiscal year 2026 with an estimated ending balance. In the past, we've used our budgeted ending balance, and we think it's more prudent to try to get a more up-to-date number based on what we know halfway through the year and extend that into our forecast period. So kind of looking through the process, as we trued up our beginning balances, the fiscal year 2025 actuals, we had an estimate of $451 million of our contingency. The actual estimate was $488 million, which was $37 million higher than what we had budgeted for. And then as we work through our projected ending balance related to fiscal year 2026, we're estimating revenues and expenses. We're estimating that our contingency reserve estimate will be at $441 million. This is we're estimating the starting point for our fiscal year 2027 at $441 million. And then our forecast period, which is the last box on the right, is generated just through awareness of the board-approved health equity plan and board-approved system OKRs that have been approved. And then we also look at cost trends and actual known future events, including the opening of facilities. And then last but not least, we just use different methodologies to develop assumptions related around the nature of revenues and expenses. So I'm going to turn it over to Nikki for the next few slides.
We thought we would share some tax information since 90% of our revenue comes from taxes. This slide shows the main categories in Travis County. And this is a breakdown of the percentage of the taxable value as a whole by category. The categories are commercial, industrial, other, and then residential. And then we also show a breakdown of, for the 55% of the value that's residential, how much of the value has homesteads and how much does not. With homesteads, 63% of the value is homesteads, and then without homestead, 37%. And this can be investment properties. Some people own 2 houses, they can only claim 1 as a homestead. Those are the scenarios for that. Next slide. This was a slide from the March presentation from TCAD, the Travis Central Appraisal District. It has the increase and decrease in values, taxable values for the main categories. Commercial did go up a small amount, and so did residential. It went from 3.52, or the market value increased 3.52%. The taxable value increased 4.7%. Business personal property is not a huge amount of the total value, but there was a large exemption that was implemented in 2026 from, they get, instead of $2,500 exemption, they get a $125,000 exemption. So that's what decreased that value, was that exemption. Next slide. Currently, new construction for taxes is the main source of our new revenue each year. And so we thought we would just show you some examples of some very large commercial real estate properties that are going on the tax roll. So Google did a very long lease with, I think Cousin Properties bought Sail Tower, and they are moving in. Commercial property is valued based on how much it's occupied. So that's going to be a large increase for coming up. Waterline Tower, I don't believe it's open yet. That should be coming on board sometime in 2026, early 2027. And then, of course, the Tesla Gigafactory is a magnet for all sorts of new properties. Next slide. So when we were estimating fiscal year 26 revenues and expenditures, we are estimating, our budget estimated that we would have expenditures that were over revenues in the amount of $132 million, which means we would dig into our reserves by $132 million. However, we're estimating, based on many different things, trends, known events that we know are going to occur, to use only $47 million of the contingency reserve. And the slide shows some high-level reasons why. We're $12 million over in the revenue budget. $2.4 million of that was a tobacco settlement. And then $5 million is because we acquired Northview, and now we have that lease revenue. And interest revenue continues to remain high. We also had a large ingestion of cash due to the debt issuance, and so that's a large increase in revenue as well. For expenditures, direct services, we have them estimated at about 75% of spend of the budget. We're not going to transfer the $15 million that we budgeted to put into the capital reserve for capital spend due to the debt issuance. We did not need it. We're estimating to spend about 87% of our budget for this year. We did use some assumptions in our forecast. That is in this presentation. We are using an 8% increase in taxes year over year. We also included a reasonable new construction taxable property value each year based on trends and also some known properties that we know are coming on board. Also, due to our debt issuance, we have in the past couple years, cash funded several projects. But when we issued the debt issuance, we received proceeds and we're able now to be reimbursed for some of that cash that we put into those projects. And that's going to be $91 million. So we are estimating in 2027 to be able to do that. Interest rates, we have them slowly going down, as well as our cash balances right now. As we spend on projects, cash balances will be going down each year as well. So we have those declining. And then we are increasing our third-party revenue, patient revenue. Since we're on Medicare, we've approved for Medicare now. We're hoping to get Medicaid approval. And so we're hoping that increases. Turn it back over to Jeff.
Next slide. Okay, some of the assumptions related to uses of funds or expenditures. We have a number of facilities that we're opening during the forecast period, and so we have estimated the operating cost of those facilities in addition to increasing patient access. So we're estimating an increase in healthcare spend due to the increase in access, seeing more patients in the future. Additional mental health crisis center funding. There was a presentation a couple months ago related around the crisis center and redeploying some funding. We've also added an additional $3 million in this year. There's a lot of undergoing discussion related around mental health and how that can be solved. We've taken a real base approach to it based on what we know today. I would anticipate over time we would definitely have some additional funding requests that might be considered by the board related to this area. But from a base budget standpoint, that's where we started. Continued investment in community care to reduce patient wait times and increase access to services. From an ongoing standpoint, in the forecast, we're also trying to invest in areas that we can provide internal services where we're not relying on third parties, and that we can provide those services more efficiently and more cost efficient. Additional capital requirements for Sendero is required by the Texas Department of Insurance. They stipulate a certain level of capital requirements, and we have put some initial numbers in to satisfy some of the more immediate requests that we are anticipating coming in fiscal year 2027. Annual inflationary rates that we use, the trending part, are averaging a range of about 3 to 7% in most instances. Most expenditures, including new initiatives and service lines, are assumed to be ongoing throughout the forecast period unless there's a known limitation or life of that service or spend. There are a few new specialty service lines. Some of them are a continuation of fiscal year 26 services, including filling some of the challenging service areas that we've had, in particular around the recruitment of providers, and developing more depth in fiscal year 27 service areas where we have single providers or very little depth with high demand. Next slide. So we're going to go through a couple of charts. I'm going to try to really pay attention to telling you what you're looking at, because sometimes it's confusing. Are we looking at dollars? Are we looking at days? So this first slide, and just stepping back a little bit, it's important to realize, well, let me back up. So this slide is in millions of dollars, and what we're showing a couple of things. We're showing sources and uses over the forecast period, so fiscal year 27 through fiscal year 31. And then we're showing a running reserve balance over those years. So for example, in FY 27, we're showing sources of 566 million, uses of 607 million. Our total reserve balance is at $492 million. And that carries throughout the forecast. And then the second part of this graph is a graph of sources and uses, and it shows what the gap is between the two on an ongoing basis. So, for example, in fiscal year 27, we're showing a gap of $41.1 million. So in other words, our uses or expenditures exceed our sources by $41.1 million, and we would anticipate drawing reserves down by that amount. And then that carries on throughout the forecast. So what's important to realize is that in this chart, expenditures exceed our sources or our revenues across the forecast period, but it's narrowing over time, and that's a trend that we want to pay attention to. That reflects that revenues are catching up with our expenditure growth as we spend down our reserves, and that, again, we want to look at financial sustainability. At some point, there needs to be an evening out of those two lines. Total reserves decline over the forecast period of approximately $207 million. So this is one of the reasons why we do a financial forecast, and again, we've used this in the past. We try to identify trends, we try to work on some of the areas that we need to provide, that we need to possibly take action on as far as it relates to long-term financial planning and providing healthcare services to our community.
Jeff, there's a quick question.
Yeah, it's a
from Manager
clarification
Jefferson.
question. Yeah.
Yes.
Yeah.
So this sources and uses, so these reserves, is this the contingency reserve or is this something else?
It's all reserves, so we have
Okay.
3 reserves, and I have a slide that's gonna show
All
our
the
reserves.
sources of the
Right,
reserves?
but we have 3 reserves in central health. We have a emergency reserve, we have a public health center reserve, and then we have the contingency reserve.
Yeah, I think you'll see it.
Yeah,
There's a
there's a-
following slide. It will
Yeah.
outline it.
But, and this is all, this is all reserves. Okay, next slide. So this is looking back at a little history of where we've been and where we're at. So again, this is in millions of dollars, and these are all reserves. And there are really 3 lines that we're using in this comparison. So the first line is our health equity plan adoption. We did a forecast in August of 2023 when the plan was approved. And so the orange line shows what our reserve projections were at the adoption of that plan through fiscal year 30. And so you see the trend and then the ending balance for the health equity plan forecast at $269 million. The second line, the green line, is our final forecast from fiscal year 2026 when the budget was approved. And looking at that trend, it's a steeper spend, and the balance at the end of fiscal year 30 was $185 million. And then our current estimate that we're showing today shows our, which is the dark blue line on top, shows the trend over the forecast period with our ending balance being at $312 million. So we produced this slide just to give the board a little context of where we were estimating historically and where we're at today as it relates to cash reserve balances. Next slide. So one of the mandates that we have through the Travis County Commissioners Court financial order is that we present what's called a no new revenue budget. And what that means is that we would show a proposed budget without a tax rate increase that would only include new construction property that Nikki had referred to previously. So this shows 2 tax rate scenarios. Now this is in days of cash. So, days of reserves, sorry. So that's our financial metric. Remember, our financial metric is targeted days of reserves between 120 and 150 days. And that's that green band there across the bottom of the chart. And so the 2 scenarios that we look at, so our tax rate scenario in our forecast is an 8% year over year over the no new revenue rate year over year. And that's what you see in the top line, the dark blue line, which was the same as the preceding slides, except now we've switched to days of cash, days of reserve instead of a dollar amount. So we're at 150 days of reserves at an 8% year-over-year tax, over the no new revenue rate, tax rate. The second scenario is a no new revenue rate, so a 0 increase in tax revenues with an 8% increase thereafter year over year. And you can see on the bottom red line that the days of reserves on hand falls to 54 days. And so there's a couple of things going on here. The actual difference in fiscal year 30, fiscal year 27 is $30 million. So that's the difference between the 8% and the no new revenue rate. And because of the compounding effect over the forecast period year over year, aggregately, it affects our total reserves by about $182 million over that 5-year period. So remember, you're getting, when you have a tax rate increase, that rolls to the next year, and so that's the impact of the 8%. So I'm gonna pause there for a second. Okay, I'm gonna move on to, let me finish the presentation.
Yeah, if you can wrap up and then we'll
Yeah.
take questions.
Okay, so the next slide, and thank you for the lead-in. This is our reserve architecture of the entire central health system. So it's central health, community care, and Sendero. So each entity has distinct reserve requirements, and this diagram shows how they fit together. So central health targets reserve levels of 120 to 150 days of reserves. And then if you look at the at kind of the top there, you see the 3 reserves I was alluding to, Manager Jefferson, on your question. The emergency reserve, which is 15% of recurring expenses, the public health center reserve, and then the contingency reserve. And then also in the public health reserve, you see a $12 million match in community care that their board has approved as a reserve level. On the community care side, the reserve criteria is 30 days of cash, and that does include the $12 million public health reserve on that their board has designated, plus any net income that would contribute to maintaining the 30 days of cash, knowing that budgetarily, from a community care standpoint, that Central Health funds community care, funds services to maintain that cash level. And then on the Sendero side, the reserve metric is 300% of risk-based capital. And this is a metric that the Texas Department of Insurance dictates, that they govern the risk-based capital level, and that anything that falls below that level, TDI can trigger a potential corrective action plan. So the intent of this slide is to illustrate the layered entity framework of our reserves across our system. And it's also essential that Central Health has reserves that are sufficient to sustain financial stability across the Central Health system. Next slide, please. So this is a slide of our upcoming calendar. We're here on June 24th presenting our financial forecast. We have scheduled our next presentation for our proposed budget on July 29th. And then we come back in August for subsequent presentations as we start setting our tax rate and our public hearing requirements, with our vote on the proposed tax rate being on the 27th. And then I believe recently, the Commissioners Court was recently scheduled for August 20th to present the proposed budget. And then you see the additional dates in September. So in closing, what I would say is this is the start of a really long process. We're happy to take any input or questions that the committee may have, and look forward to presenting the proposed budget next month. Thank you.
Thank you, Jeff and Nikki. Appreciate your presentation. Again, members, I apologize, I just stepped in, and thank you, Chair, for taking the lead. As you mentioned, Jeff, this is the start of a conversation. I'm sure we have many questions, both us and the public. So I am gonna ask you a couple questions, and then I'm gonna go around the table for one question if you have any thoughts. And we're gonna bring this back again, but also in the meantime, if you have any questions or anything, please let us know as we're preparing. This is the first time this is the start of the beginning of our budget cycle. Now, I have a couple.
Manager, can I add one comment before I forgot to say?
Yes, go ahead.
I do want to, this was what our practice was last year as we presented the proposed budget, as changes were made. We dragged the forecast along with the process so that we could see what the impact was in the current fiscal year and out in the forecast period. So apologies for not mentioning that, but I just wanted to make it clear that we'll drag this forecast schedule throughout the process so that we can at least evaluate what some of the changes may be and how it impacts our future finances.
Thank you. I have a request, and perhaps I've never really asked this before. Could you provide us our tax rate increase for the past 5 years? Could we see the trend for the past 5 years? Where have we been? Where did we start? And how things? I think that will just give us a picture of where we're headed. That would be helpful. Second thought, I have a question on slide 10 of your presentation, 42 of our packet, I believe. Now, I understand that we issued COs for Northview and Promontory Point. Could you explain why? I assume when you issue COs, there's different funding mechanism. Why is it included in the budget? If you can just give further clarification, because it's a little confusing on my end that we issued and now it's part of our assumptions. So that would be helpful. And before you answer me, just out of, I saw also on page 12 of the presentation where page 12, where what you forecasted and where we've ended estimate. So I'm just trying to do, so when you forecasted for fiscal year 26, did you underestimate? And now we're only, in terms of where we're at, so in terms of your modeling, if you can just also touch on that and how the actuals the current estimates are different than the forecasted for the 26. So those conclude my questions. I don't know if you would like to answer them.
Let me work backwards if I can. Although we'll do the 5-year tax rate, we'll bring that back.
Okay, thank you.
As part of the proposed budget. So as it relates to slide 12, the reserve comparison, so when we completed the FY26 approved budget forecast, and I'm going to point right to the $185 million, there were a couple of things that have happened since then. So one has been we've trued up to our actual audited numbers, so that was a difference. We estimated our FY26 reserve balances rather than the approved budget. And then probably the biggest part of the difference would be when we did the forecast, we had not issued debt, so we were on a cash-funded capital project budget. And when we issued that in November of 2025, that debt issuance, when we bring the cash back from the capital projects fund, is how I look at it, it will increase our reserve balance. It will increase our contingency reserve balance. So when we issued that, the plan was to free that cash funding up and move it back to our operational side. And so that's one of the bigger differences as it relates to the difference between the 185 and the 312 million. On slide 10, on the facilities, so yes, we issued debt for the facilities. That's for just constructing, purchasing, presumably purchasing the land and constructing the facility. But on our budget, we also, when the facilities open, we have to budget for operations, and those facilities will be providing services also. And so we want to budget for an increase in services in those facilities. So we try to stage when we think the facility's going to open, and then we, again, budget for operations and for additional services.
Okay. My last thing before I open, and I don't know if Stephanie is here, perhaps within those new facilities, if we can have a timeline estimated of your, whatever the cost of the acquisition, the facility, and operations, it could be helpful as we're planning, I think, moving forward.
She's there in the audience.
Oh, yeah,
Stephanie?
but, yeah, you heard me. Okay, thank you. So I'm gonna open the floor. Manager Jefferson, I'm gonna start on your side.
Not so much of a question, but just an observation. I see on the slide 11, sources and uses forecast and the rate scenarios and so forth. The slope is going down, and so I guess you will give us some information at future meetings about the sufficiency of these reserves for what we need to do, yeah. Mhm. Yeah. The slopes are going down, it looks like, in all the projections.
And we had anticipated that, our reserve levels are higher, and we, as part of past financial forecasts, we had a forecast that showed reserve balances decreasing as we spend those down. And so we're seeing what we expected to see as a pattern. What we want to see on this slide at some point as we look at future periods past this forecast period is the flattening or the decreasing even further of the gap between sources and uses. And so some of the, we don't have it here, but some of the modeling that we've done by fiscal year 33, we have closed that gap. Again, based on the assumptions that we carried forward.
And these assumptions are based on the health equity plan that's pretty much winding down, that particular plan, and not so much, we're in the process of a strategic plan for the next phase.
Yes, so the plan, it would be fully implementation of the health equity plan, which is through fiscal year 30. And then, of course, there are ongoing costs past that period. You don't implement it and then stop providing the services. So we've carried that forward, and I believe by about fiscal year 33, we had closed the gap on some of that.
Thank you. Manager Matwane?
This all tracks, thank you, Chair. This all tracks and makes sense. I appreciate it. And I look forward I want to thank you all for architecting, I think, a structure that has, for this process, that continues to improve year over year as it should. you know, it puts us in a place where we can more appropriately, instead of getting bogged down in maybe the details, which of course are important, or the granularity around the structure, we can really discuss sort of the prudence of the higher level initiatives that we're moving forward through the lens of taxpayers and beneficiaries who are an overlapping group, you know, I should add, and how we achieve what I call the dual bottom line, the moral imperative of doing the right thing to get those who need care, the care they need, and also doing the pragmatic thing, which is fiscally prudent. So thank you all so much. Thank you, Chair.
Vice Chair May, your microphone.
Yes, thank you, Jeff. Thank you, Nikki, for the work. As usual, you come up with some really good information for us to really digest. That being said, if you could go to slide 46, where it has to do with the reserve overview, my question is this. Does Central Health, because it has 100 to 150 days of reserves, do we have, and we should know this as a board, but I don't know the answer, so I'm gonna put it out there. Do we have a policy on the reserves? Is that the policy that we have on the reserves on the book? Okay, so the answer is yes. The next question is, and this is a much broader question that would have to be taken to some of the other organizations, but I am wondering if there's any value in us aligning to each other's reserve policy. And I know that it's gonna be a little different for, like, for example, Sendero. It's I understand that it would probably be very different because of the insurance product, you know, item. But that being said, I'm just curious to know if that is something that we could do so that we're aligning ourselves organizationally across what would be the system of the future. That's just a question. Maybe it's more of a question for us.
Well, Jeff, remind us what our reserve policy is. It
Yeah,
is
so
15
there,
or 20%?
so on the contingency reserve, there's not a set days of reserve. It's actually, we look at our forecast period, and then based on our bond rating and certain financial metrics, GFOA best practices, based on the type of entity that we are, at the time, 120 to 150 days was the prudent days of reserves that we needed to maintain in order to maintain our bond rating, which is AA+. As far as alignment of the reserves metrics, we're different types of entities. Central Health is an entity that we get about 90% of our revenue 3 to 4 months into the fiscal year, and then that's the other 10% it's spread throughout the year. So for us, it's important as we end our fiscal year at September 30th, if something were to happen, that we could go at least that 90-day period, have reserves, cash reserves, so we're not having to temporarily debt finance things like payroll, vendors, et cetera, et cetera. Community Care is a little bit different. They're an ongoing service provider. They provide services on a daily basis. They bill on a daily basis. They have a constant cash flow that comes in. So it's really, they don't have those long periods of time where they may not have any cash flow. I think I heard Joy mention that one thing that she has to look at is 2 months in the year, there's 3 pay periods. We get paid bi-weekly, so she has to manage towards that, knowing that, you know, from a cash flow perspective, she's still trying to maintain her cash level. So it's a lot different cash flow profile. I don't know that in our current structure that we would want to do that, but we can certainly look at that over time.
Thank you.
Thank you.
And Manager may remember that in the community care standard terms and conditions of our payment to community care, we actually require them to have 30 days cash on hand. So we're actually limiting them on their days cash on hand. I have like 6 different comments here. So one, I want to make sure that I want to ask these questions or ask these requests out of a governance perspective and out of the values that this board has been espousing that I know of since I've been on this board of transparency, accountability, responsibility, and dignity of the person, to respect the dignity of the person. Like, first of all, when you say 3 to 7% inflation rate, I would expect that at some point in the future, you'd actually give us the specific inflation rate, because 3 to 7 is a range. And I think when you're doing forecasts, I think I'm trying to figure out the clarity about kind of where we're going. And I'll give you another example in your assumptions on slide 42. You add here that we have an additional mental health crisis center future funding of $3 million. Well, this board, from a governance perspective, has never approved that. We've never voted on that. So that's a little bit of a surprise to me. I think the other thing is on page 12 of your slides, when your forecasted date, I am really reticent about these 8% increases in budget. I would really love to see on the forecasted date, you have a line there that just says no new revenue, so that the board understands the gap that's there and what risks associated or what things we won't be doing. Because I think it's part of our fiduciary duty to be very clear-eyed about what our known net revenue is. Because if not, you're making an assumption that this board has made an approval that we want to increase by 8% the taxes on every single year, with the limitation that the legislature might be cutting that. So I don't know where this
I just
8%
want to be
is coming
clear.
from.
I want to be clear. We're not making that assumption.
Your
when we
slides
do-
are saying that.
Well, we have to make some assumption in a forecast process. The first thing that I said was I'll be more than happy to take any input. We've done that historically. If there's any scenario that a board member would like to see, we always bring that back. So I understand what you're saying.
Yeah.
But we've got to start with a base period at some point. If we want to see something different, I'll be more than happy to.
And I'm saying the assumption should be, no net revenue. I'll give you an example of why I say that, because I don't say that just out of turn. I think for me, balanced budgets are really important, but so is the fact that, for example, Nikki just reported to us you're estimated to spend 87% of the total FY26 budget. That's 13% less than the budget than this board voted on. And then on top of that, you're asking for another 8% increase as an assumption. So I'm just trying to get clear-eyed about our fiduciary duty, the known net revenue assumption, and then to understand what that risk is of that gap that we're gonna do. And so I'm just trying to get a hand, and I know you're doing this for 5 years, which is really difficult to kind of do. So in all of that, you're doing an 8% increase, you're assuming 3 to 7% inflation rate, and you've got a 13% reduction in the spending that you're doing in the budget. And I don't know what the budgets were in the previous years, but I'm just trying to get more sense of like what exactly we're putting our arms around, so that we can understand when we're investing in potentially a mental health crisis center, that we're being intentional, thoughtful about what we're doing, and we're very clear-eyed about the strategy that we're using, because we don't have one because we need one, and it's aligned to our facilities plan, which we don't have one, but we
That's
need
right.
one. So to me, I'm just trying to be clear-eyed, because I'm very reticent about supporting increases when we don't have an updated strategic plan, when we don't have a facilities plan for the first time, and we're trying to understand where the tax rate is at around no new revenue. And so I hope that's helpful, because I think this is, and I appreciate you all bringing it in, because I think this is important to have an iterative, generative conversation about kind of where we sit around the assumptions that we're making with these slides. I think the last thing is, I think whether we review or explore, we need to understand our reserve policy, and whether 120 days is appropriate or whether it's 20%. Our friends in other governmental entities like school districts here have gone down to 10%. That's not where we want to go, but I think it's important to understand kind of what our assumptions are around that. And so to me, I just want to be more clear-eyed about it, which is why I'd rather ask these questions now versus when we're about to like vote on a budget. So, and I'll stop right there. Thank you.
No, I appreciate your insights. They're very
Can I
helpful.
make a couple comments? Thank you for the comments.
Yes.
Historically, we have budgeted as a I'm going to call it a full service provider. So we're trying to anticipate when we stand up service lines. There's a lot of variables. We don't hire a lot of support staff if we don't have the providers to lead that service line. So I would expect, unless everything happens perfectly and we are able to fill positions exactly as we forecasted or budgeted, that we would be below. So that part of it, it's part of, in the budget policy, conservatism and providing services. So that part of it, I think we do. And then as far as the reserve levels, I talked about at the end of the fiscal year, and when we get 90% of our revenue being at the end of December, that's a 3-month period. That's 25%. If you just want to even out the spend, that's 25% of our spend. And so we're going to need a higher level of reserves than a 20% amount if we want to be financially prudent. So that's my rationale. And then lastly, from why 8%, part of my job is to present a model or a forecast that provides some financial sustainability, and we're trying to target our days of reserves on hand, knowing that there are probably going to be some, we're presenting a base budget and that we will possibly have some additions as we go throughout the budget process and look at priorities. So I just wanted to give you a little more context of where we come from.
And my other question is just, do we use a commercial paper as part of our budget process or not?
No.
We don't.
Commercial paper as an investment
In
instrument?
other words, no, when you budget and if you're getting your money in December, right, so you have a 90-day gap, and I would expect that with your reserves, you probably don't need it, but if you have a gap when you get your tax revenues, a lot of times our governmental entities do commercial paper to bridge through, which is short-term loans at 0.5,
We
1% kind
don't
of thing.
deploy that,
Yeah.
and that's a really expensive financing option. Tax anticipation notes are.
No, not tax anticipation notes.
So-
Well,
This is
we
short-term.
we don't have a commercial
But you
paper
answered my
program
question.
that,
Yeah, thank you. Dr. Martin?
Kind of segues to mine. In what financial instruments are the reserves held?
Per our investment policy, things like, a lot of it's held in the local government investment pools. But we also hold some bonds from local governments or state governments, a few of those, and then the rest of it's made up of things like treasury notes.
Okay.
So we follow what's called the prudent person rule in the Texas Public Funds Investment Act, which is the first priority is safety, the second priority is liquidity, and then the third least priority is return.
Spoken wisely. This segues, and this might be a question for you and the assumptions as well as CUC. In the CUC presentation, there was a note about 12% vacancy rate and of providers, and there's an assumption that we're going to increase revenue by increasing patient access. And the question is, how are we going to do that without doctors and providers? And this is kind of a question for CUC. I mean, so number one, is that a fair assumption since we can't find doctors? And the question for CUC is, what is sort of I understand there's a shortage, but what is what is the rate limiting step to bringing more providers on, since that is our primary job to provide healthcare, and that's where we're kind of falling short, and it would also, I think, increase the assumption, because the CUC physician workforce seems like they're working pretty hard, where that assumption can be safely made if we're get a bit against this roadblock about recruiting more providers.
Hello, Tara Trower, Deputy CEO for Community Care. I actually thought we were going to get this question when we presented our financials earlier. Yes, we still have a provider vacancy rate, working a number of different levels and levers to correct that. In our senior leadership team this morning, we did hear that we have think out of 24 spots, both anticipated for new builds as well as the current vacancies, we're only short 2 currently in terms of anticipated start dates. One of the challenges when recruiting providers is that there's a pretty long window, and so that's if no one else retires, but we are looking collaboratively with Central Health in terms of changing our compensation structure to make the jobs more effective. Also looking at what's going on with some of our workforce in terms of we have a number of providers who would like to work 0.8 or 0.6 of an FTE, which is shortage. So we're really taking a comprehensive approach to looking at it to address exactly what you describe in the future. So it's complex. We've got a lot of folks working on it, but at the end of the day, there is a shortage, and so really in collaboration with the people team, trying to build a strategy and structure between MDs and APPs and using nurse visits and some other things to make sure that we are able to get the access that we need, given that there is an overall national shortage in primary care providers.
What seems to be the most rate limiting step in hiring doctors? Affordability in Austin, or the work?
So there are several things, and I won't provide an exhaustive list. One, in terms of our clinic locations, there is a bit of a mismatch between where providers wish to live and where we are delivering care. That providers that, particularly if they're co-hires from the University of Texas, they tend to want to live closer inside the city. It is much harder for us to hire place physicians in Del Valley and sort of that Eastern Crescent area where we have a high degree of need. It also depends on service lines. One of the areas that we are challenged, as with many others, even more than family medicine, is women's health. For a whole variety of reasons that I will not get into here, but you might be able to surmise. We have women's health providers who are leaving the state, and so we're going to be continued to be challenged in that area as well. We are fairly competitive with pay, but we don't offer incentives, which is one of the things that we're working on for those providers who do want to see more patients to really adjust our scale. So again, we're looking, I don't know that it is any one thing, but we are trying to figure out what are the things that we can do as a system that will get us the highest results we can get out of this constant hiring cycle, because there is a cost to it, but we're gonna have to be creative.
Thank you very much.
So Dr. Martin, you bring a really great point. As we're expanding, building new facilities, and we're putting into account operations, and yet here we have a healthcare provider shortage across. And we're not able to fill those positions, but yet our assumptions that for our budget is built on those operational costs. So I just see it's not adding up. So that's the concern. Like, and who's bearing the cost is our taxpayers and our patients, absolutely. Absolutely. So I'm just trying to see the mismatch.
I get, and I.
So that to me as well, as we're thinking, I will recognize you, Management One, in a second.
Yeah, but I think it's a good point. I think y'all are, I really think I know the difficulties specifically. But I would argue that, if anything, that's something we need to overspend on, since this is why this whole organization exists. And I understand being competitive, but we have an enormous unmet need. So I would just, as a budget assumption, I would push for that. So, but thank you.
Thank you. Management One, is it related? Can I open it to the?
It's related. It's related to exactly what you were just talking about, so it's as you wish.
You can go ahead and really quickly, and then I'll take your questions.
It's kind of you, thanks. No, the point was, if you're seeing a mismatch in, inability to sort of recruit, and therefore variance in what we budget, and then of course increasing in budget, when I see, and to Dr. Martin's point a little bit, when I see that there's a national shortage, the economic equation for me says the one variable that you can tweak in this is the dollars. So if somebody doesn't want to live somewhere, if somebody doesn't want to relocate somewhere, the one variable that changes those things is the economic incentive to be able to do so. So that would actually probably mean that it would be an overspending issue later. Thanks.
Thank you for your point. Manager Valdez?
Yes, just in case we hadn't thought about this historically, the reason we purchased the Sears building was because that was based on a survey that was sent out to the employees of Central Health. Where did they want to work? And the location was bought because the majority of employees wanted to be in central Austin, not anywhere else. So we bought that property based on the desires of our employees, not necessarily our patients. And that was exactly what Mike told us when we made that decision. So aside from that, that's historically factual. And that's what Mike told us.
I don't agree with that.
He said that there had been a survey
Well,
provided to the employees, and the majority of the employees wanted to be, that was like the center point
We
of
can
where the majority of
revisit
employees
that
were.
and get some further clarification
Yeah,
on
it does,
that end.
that's fine. But to my concern is that why are we continuing to not operate on a balanced budget system where our uses equals our sources? Because we're using the contingency or other reserve funds to be able to pay those overage costs. And that's not real world. And so as we, as taxpayers, have to balance their budget, I cannot spend more than I have in my bank account. So I just got to eat it. So I want to know, when will Central Health take that into consideration and not spend more than we have allotted for the budget of Central Health? And it's very simple for me, because I continue to hear this, and I continue to hear justifications. Well, the justification to the patient, just like to the taxpayer, because we're all taxpayers, whether we have the money in our bank account or not, we're all taxpayers. So why don't we just spend within our means? Aside from that, I guess I can send you all a lot of questions, but basically it's basically around that. Because as I look page after page after page, we're covering overages with our reserves. And we are lucky that we have the reserves, but that's because we do our 8% year over year, or we're underspending in the provision of services, which I personally would rather overspend, and I would rather have services provided for. This is what we need to have based on the needs of our community, surveys, and the facts. So if our community needs these services, these are the services that we'll be providing. And live within those boundaries unless an emergency or a crisis occurs. And then to me, that's what the contingency is for, an emergency or a crisis, not just to, you're telling me it's not. Okay, so then explain to me, why are we continuing to, as I'm seeing the numbers you provided us here in these sheets on page 11. The sources, 566 million. The uses, 607 million. I mean, and that's year after year after year. And so I just want to know why we are not spending based appropriately, based on our income.
So if I'm hearing you correctly,
Our budget.
you're saying that our uses exceed our sources. Is that what you're
That's
implying?
exactly right.
Oh, okay.
So we're always operating, we operate every year on a loss.
So this is, again,
And
a
we're
conversation the
that's
board
right.
can make.
And we're using
a
our
policy.
reserve funds as we're compensating for the losses based on our reserve funds. And I don't know that those reserve funds, I don't know where the actual limitations or deficiencies are, because I would want to know that it's not in services. I want to make sure that we are providing 100% of services needs and not
Understood.
something else,
Thank you.
okay?
Manager,
And one more question,
Yes.
just one more comment with respect to our workforce. I want to make sure that our workforce, especially the providers and the frontline employees, are getting paid salaries and not operating on hourly wages for year after year after year.
Well,
So
I
at
don't-
some point in time, we'll have that conversation.
okay, we can, but from my assumption, understanding there are salaries unless there are contracts, if that's correct. Again, I could clarify, we can go into this.
We can have
We'll
that
get- we can
conversation
get-
with
we have
HR.
HR, we can get
That's right.
further
At some
information.
point in time.
Thank you. Manager Kitchen.
I will send you my specific questions. I have two overarching comments, and they relate to, one area I'd like to see additional detail on the services that are projected, both for this year and out in the future. So for example, I'm wanting to understand, I think I heard you say, but I'm wanting to make sure I'm understanding that we're projecting completion of the health equity plan. I think I heard you say that. Is that right? Okay. So I'd like to see, you had mentioned, for example, building out some more services and getting them into depth and stuff like that. So I'd like to see the detail on what we're projecting on anything that's new, how that relates to the health equity plan. So that's one thing. Second thing is, it's a governance question, and it may be more for our chair and vice chair, but I think I need to understand the timing related to our strategic plan. So because I'm not as concerned about 2027, but this projects out to 31. And so I would like to understand what's in this budget so far that might be something that's in our strategic plan that's not in our health equity plan. In other words, what are we assuming? It kind of goes a little bit back to what the chair said. I'm on the mental health funding, I am happy to see that flagged, and I appreciate you flagging it, because we know that we're going to have that conversation. As a board, we haven't yet, as the chair pointed out, but we're going to have that as part of this budget cycle, because we know that we've got, if nothing else, we've got to talk about the diversion center and other things like that. So that's just one example. I want to make sure, that I know about. I want to know whether there are other areas like that we are foreseeing potentially in the future. And so it's kind of hard to do that because we don't have a strategic plan. So I think I just need to understand how we're going to align our timing around strategic plan with our
Budget.
with our projections. And it may be that we just say, these are the projections now, strategic plan's finished next year, we're gonna have to change projections then. But as much as we can, I'd like to anticipate what areas we know we're gonna have to think about more dollars. So anyway, so that's kind of the overarching. I do have some specific questions, but I'll send you those.
Thank you, Manager Kitchen. I think you really bring up a great point in terms of aligning our budget and projections with our strategic plan. But I also want to remind folks with the health equity plan, things evolve over
Yes,
time.
yes.
And what may have been in that assumption may
Right.
overlap with our strategic plan. So we also may need to rethink that as well as we're moving forward.
And that's fine, Chair. I just want to know about
Oh,
it.
absolutely. And again, this is the first time that we've been all presented with this, and we appreciate all your inputs. Jeff and Nikki and everyone heard them well and loud. And again, thank you for your time and for your work. Thank you all. And with that, we're going to move on to our next agenda item. And it is agenda item number 5, I believe, and we will be going into closed session. So we are going into items for closed session for items 5 and 6. Item 5 is receive and discuss financial and operational updates from Sendera Health Plans. And agenda item 6, receive a briefing from council and take appropriate action on a report on current community-based organization contracts. And we are convening, I announce that the committee is convening closed session to discuss agenda item 5 under Texas Government Code 551.085, governing board of certain providers of healthcare services, and agenda item 6 under Texas Government Code 551.071, consultation with attorney. Thank you. And it is June 24th, 2026, and it's 5:43 p.m.
He's squirreling it away.
Yes, that's a good one. Okay, Edwin?
Okay.
Well, good afternoon or good evening? Good evening, everyone. It is still June 26th, June 24th, 2026, and it is 7:30 p.m., and we are out of closed session. We discussed agenda item number 5, which was receive and discuss financial and operational updates from Sendera Health Plans. There's no motion to that item. Now, for agenda item number 6, receive a briefing from council and take appropriate action on a report on current community-based organization contracts. We do have a motion on that item, but I am going to recognize our Travis County attorneys, David Duncan first, and then we can take a motion from the chair.
Members, there is a provision of the Central Health bylaws regarding the Budget and Finance Committee that allows the Budget and Finance Committee to take action on behalf of the board. It has standing authority to act on behalf of the board with respect to certain items. One of them is expenditure funds for goods and services. If there are at least 7 members present, at least 5 vote for the motion. This is relating to expenditures. It is authorizing RFPs, and those will ultimately result in expenditures. So it fits within this, but you have 8 members present. If 5 vote for this, this is action of the board, which is actually how the motion is worded.
Okay, thank you. I'm going to recognize the chair.
Thank you. I move that the Budget and Finance Committee act on behalf of the Board of Managers to direct staff consistent with the board's current community-based organizations policy to 1, issue requests for proposals for all community-based organization contracts for fiscal year 2028, and 2, for contracts supporting outreach related to MAP and Affordable Care Act enrollment assistance. The RFP should be limited to outreach to Travis County residents and should be focused on the residents at or below 200% of the federal poverty level, and possibly outreach to persons above that level if justified by the bidder in their proposal as serving patients consistent with Central Health's mission and not to exceed 300% of FPL.
Thank you. Do I have a second? I have a motion on the table at the chair, a second by Manager Valdez. Any discussion? Manager Kitchen?
I'm going to support this motion. I think it recognizes the value of the services we're receiving right now, and it recognizes the importance of working with our CBOs by looking at an RFP process in 2028, not in 2027. And I also think it focuses on the population that we serve, the second aspect of it. And I think that's really important, and that's what we have in mind, is really serving those folks in Travis County that are either at 200% or possibly 300% of federal poverty. So that's why I'm going to support it.
Thank you. Any further discussions? I see none, so at this moment I'm ready to take a motion. All in
The vote.
Oh, I'm sorry, a vote. I apologize, it's been a long day. All in favor?
Aye.
The motion passes unanimously. Thank you all members. So at this moment, I am ready to adjourn our meeting. Members, our next Central Health Board of Managers meeting is tentatively scheduled for Wednesday, July 2026 at 4 p.m. at the Central Health Headquarters, 1111 East Cesar Chavez, Austin, Texas 78702. At this time, I'm ready to accept a motion for adjournment. I have a motion by Manager Valdez, a second by Manager Matwani. All in favor? Aye. We're adjourned. Thank you.
Good evening. Today is June 24th, 2026, and it is 7:35 p.m. As a quorum of the board is in attendance, I'd like to call to order the meeting of the Central Health Board of Managers. As a reminder, some of our board members may be also participating by video conference, so the staff will be managing video and audio feeds of all participants closely to make sure we have a legally compliant meeting at all times. We're going to proceed to public communication. And I'd like to announce that in order to make it more accessible to community members, we held the public communication for the Budget and Finance Committee at 4:00, and we're now holding the public comments for the Board of Managers meeting. And is there anyone signed up for public comment? There is no one signed up for public comment, so we are going to move to the consent agenda. And I'd like to accept the motion to approve the consent agenda.
Chair?
Yes.
I pull C2 from the
Oh,
consent
okay.
agenda.
Yeah, thank you. That should have been my first question. Are there any items other than C2 that we need to pull for a separate vote? Okay, if not, could I get a motion to approve the board consent agenda items for items C1 and C3?
So moved.
Okay, having a motion and a second, all those in favor, please raise your hands or say aye. Aye, the motion passes unanimously. And then I'm gonna take up the item that was pulled from a consent agenda and wanted to accept a motion to receive and ratify the Central Health investments for May 2026.
So moved.
Have a second?
Second.
Dr. Martin seconds on that one. Okay, so having a motion and a second, is there any discussion? Hearing none, so I have a motion and a second to vote on item C2, receive and ratify Central Health investments for May 2026. All those in favor, please raise your hand.
Aye.
All those against, all those abstaining? Okay, so the motion passes 1, 2, 3, 4, 6, 7, 4, 0 against, and 1 abstaining. And that's Manager Jefferson. Thank you all. We're gonna move to the regular agenda, and item number 1 is to receive and discuss a report from the board chair. I have 3 quick, let me see. Actually, I have 4 items. 1, the staff should be reaching out to you, or I think there was a handout asking for dates for July 18th retreat with our governance consultant. So if you haven't filled that out, I think there might be one member who is not here today that you need to reach out to, and you have that. The second one is in your packets in the appendix. There's a governance action plan. If after you review that, if there's any questions, please feel free to reach out to the chair and vice chair with any questions around that. I think the last 2 items, one is I was remiss in the last meeting to remind you all that we now have the Central Health meeting conduct guidelines at our desks that are laminated, and they go through 4 different areas that we have agreed to around meeting conduct guidelines. And I thought it was worth mentioning those for the public. Well, the first one is be respectful, that we would arrive and end on time, respect others' points of views, we wouldn't interrupt or talk over others, critique ideas, not individuals, be mindful of nonverbal communication, respect the confidentiality of discussion by not sharing individual comments outside the room. Listen is the second topic, which is listen for understanding, be open to new ideas, participate, do not dominate. The third item was to speak, to be honest and speak kindly, to speak with one voice, we, not I. Avoid side conversations, speak on the topic with clarity, aspire to limit comments to approximately 3 minutes per topic. The chair would exercise gentle discretion. We worked on that language. Avoid repeating points already made. Emphasis is welcome where it adds new thinking. And then the fourth one was around seek, which was to stay focused on governance level work, consensus, unity, action, and results. And members, we have these on our desk now as a reminder. And with the one item that I mentioned about the chair exercising gentle discretion, about 3 minutes, I just wanted to introduce where'd it go? Dr. Martin? I lost it. You lost? So I wanted to introduce this tiny little remote that as board secretary, I asked Dr. Martin if he would be responsible
I'm the heavy.
for clicking on our 3-minute timer. And so I think we're gonna test it out today because I kind of couldn't figure it out a little bit. I think Dr. Art may figure it out, but I think what we want to do is test it tonight because I kind of feel like we have been holding ourselves to like the 3 minutes with some, not a lot of exceptions, but rare exceptions. So we wanted to kind of test this out, and I think the discretion that I was talking to Dr. Martin about is that I think we would do the 3 minutes when we speak, and then just have a gentle reminder, but it's and then see kind of where that goes. And again, I think part of it is we're trying new things just to see if they can be effective and efficient for our governance work. That's really the goal. It's not really to limit people's ideas about what we're doing, but to make sure that our time is being well spent. So those were the 4 items I had on the governance on the governance issue, and I wanted to move to item number 2, unless there's any questions. Well, I wanted to move to item number 2, receive and discuss a report from the president and CEO. And I think Dr. Lee is out in Plano at a innovation conference. I think it's called the Toyota Innovation Congress. I don't know if he's online. He is. Dr. Lee, we can't see you.
Plano's for poor reception.
There you go. We see you. Yeah, the floor is yours.
Perfect.
Thank you, Chair. Members, for this month, I was asked to actually provide the update in writing, and so you have it in your board packet. I'm more than happy to take any questions on it. I can, of course, read it out loud if you would like, but in the interest of time, I'm happy to take any questions you may have on this month's update.
Yeah, thank you, Dr. Lee. Members, any questions? Nope. Good report. Okay. Thank you, Dr. Lee. Members, we're going to move to item number 3, receive, discuss, and take appropriate action on a resolution approving an amendment to the bylaws of Sendero Health Plans regarding ex officio members of the Sendero Board of Directors. I think as I mentioned in the last meeting, this was simply a change in the bylaws from shall to may around the chair being a member of the board. And the reason, I think that I mentioned last time, the reason is that I felt like I needed to spend more time here at Central Health and at Sendero, so wanted to make sure there was an option, but also didn't want to impact the governance of Sendero, because part of it is there's a requirement of the Texas Department of Insurance to make sure that as a member that I need to be there, and so that's what this item is about. And I know Manager Mawani, you're our member on the Sendero Health Board. I don't know if you want to add anything.
Nope. We discussed it, and the board unanimously voted.
Yeah. So thank you. So I would welcome a motion on this item.
So moved.
I second.
So having a motion to approve the resolution approving an amendment to the bylaws of Sendero Health Plans regarding ex officio members of the Sendero Board of Directors, and having a second, all those in favor, please raise your hand.
Aye.
And the motion passes unanimously. So now I'm going to move to items 4 through 7. I announce that the board is convening in closed session to discuss agenda items 4, 5, and 6 under Texas Government Code 551.071, consultation with attorney. And those items are item 4, approve the proposed foundation formation documents and authorize staff and council to proceed with legal formation activities and continue working with the board on the operational governance and administrative structure of the foundation, including policies addressing the board of managers' oversight of the CEO of Central Health role in respect to the foundation and foundation leadership as recommended by the Strategic Planning Committee. Item 5, receive and discuss a briefing regarding Birch et al. Versus Travis County Healthcare District doing business as Central Health and Dr. Patrick Lee, cause number D1GN 17005824 in the 34th District Court of Travis County, and services provided by faculty and residents of the University of Texas at Austin Dell Medical School in support of Central Health's mission. And item 6, receive a briefing and take appropriate action on issues related to Travis County Healthcare District doing business as Central Health versus Ascension, Texas, frequently known as Seton Healthcare Family, cause number D1GN 23000398. And then also agenda item 7 under Texas Government Code 551.074, personnel matters, and Texas Government Code 551.071, consultation with attorney. And item number 7 is deliberation and possible action on the appointment, employment, evaluation, reassignment, duties, discipline, or dismissal of one or more Central Health employees. And so the time is now 7:47 p.m. and we will go into closed session. good? Okay. Oh, thank you. Good evening. It is June 24th, 2026 at 10:02 p.m. and we're entering open session. And we are going to consider item number 4, and I would entertain a motion.
I'll make a motion. Here's the motion. I move to approve the Central Health Foundation formation documents, including the certificates of formation, bylaws, administrative services agreement with the certificate of formation revised to expressly include Central Health's approval rights over the foundation's annual operating and capital budgets and any material deviations from those budgets. Authorize staff and council to take all actions necessary to complete the legal formation of the foundation, and direct staff and council to continue development of the foundation's operational governance, administrative structure.
Do I have a second? Dr. Martin, second. So is there any discussion?
Yes.
Yes, Manager
We
Kitchen.
also had, it doesn't need to be part of this language, but I also just want to reflect that we as a board will continue the work that we need to do on developing policies related to the foundation's operations, including policies related to HR.
Yes.
Thank you. Duly noted. Manager Motwani? Good. Okay. So any other questions? Having a motion and a second, all those in favor, please raise your hands.
Aye.
Aye. And the motion passes unanimously.
Finally.
Members, we have 3 more items. I was just
Yeah.
saying that to see if anybody was paying attention. We have item number 8 to confirm the next regular meeting date, time, and location. Our next regular Board of Managers meeting is tentatively scheduled for Wednesday, July 29th, 2026 at 4 p.m. at the Central Health Headquarters, 1111 East Cesar Chavez, Austin, Texas 78702. At this time, I'm ready to accept the motion for adjournment.
Moved.
Dr. Martin, motion. Manager Motwani has second. All those in favor?
Aye.
Aye. The motion passes. We are now adjourned at
Thank you,
10:04
chairs.
p.m.
Gosh, that's late.
Thank you. Thank you, Hal.
That's late.